It is 12:05, back Dr. Payne Show on a beautiful, brisk, but shiny and sunny Saturday afternoon. Here it is just after 12 o'clock, 416-870-6400, star 640 on sale. Dr. Lou is here to answer your pain questions. You got concerns, health concerns, bring them on. That's what he's here for the next hour. Outside of the show, of course, 1-855-55-Dr. Lou, DRLOU, info@paincarecanada.com. Free consultations, that's where it all starts with the consultation. We look back, or at least look ahead to a few cases you're either working on or have been working on. What's going on, pal?
Not too much, John. How are you?
Good, man. Good.
Yeah, lot of numbness, tingling that I've been seeing lately,
Right.
for sure. I don't know, for whatever reason. I do seem to notice in practice that when we have season changes, there's a lot of numbness, tingling types of cases that coming in, and obviously whether it's numbness and tingling in the hands or the feet. But what's been very, very interesting is I've picked up a lot of, when I always break down the neurological system, you can break it down into two things. You can break it down into the central nervous system, which is the brain and the spinal cord, right? And then the peripheral nervous system, which are the nerves after the spinal cord. And those are the ones that we commonly think are affected. But sometimes when you have central nervous system problems, whether it's some type of a cyst in the spinal cord or some type of neurodegenerative disease in the brain, it can affect the peripheral nervous system
and extremities, right?
Yeah, and cause these similar changes that we would expect, like numbness and tingling, pins and needles, sensory deficits in other ways, motor deficits. And I've been seeing a ton of people who have some type of neurological symptom are coming in, and we're doing our full neurological exam with them, and we're picking up problems that are located in the central nervous system. And that's a big concern, right? So a lot of times people assume that when they have numbness or tingling or pins and needles, that it's probably, the most common thing I hear is it a pinched nerve? And that's all they're thinking, is it a pinched nerve? And you know what? In a good case scenario, that's what you want it to be. A peripheral problem would be something like a disc herniation or a tight muscle or like a carpal tunnel syndrome, things like that. We've all heard those things. Those are peripheral nervous system issues. And peripheral nervous system issues are, if you had to choose, are much better than having a central nervous system problem like a multiple sclerosis or an ankylosing or an ALS. And so a lot of the times the different ways that these things can manifest in the peripheral nervous system, they could be picked up through simple examination techniques that could be done in an office. You don't necessarily need a big MRI machine or a CAT scan machine to assess the brain, because there's a lot of specific neurological testing that can be done that can pick up if the issue is located in the peripheral nervous system or in the central nervous system. And so again, when things are located in the spinal cord in the brain, that's when they're a little bit more concerning, right? Not always. Sometimes certain things can be dealt with easier than others, but definitely when you're dealing with a central nervous system problem, that's something that needs to be identified quickly. And a lot of the times, because these signs and symptoms between central nervous system problems and peripheral nervous system problems are so similar, people just dismiss them for a very long time. That, it's just a pinched nerve. It's just a tight muscle. It's just this. That's right. And they live with months to years of this issue, not realizing that if it is potentially something neurodegenerative, then had you got it looked at sooner, you start the treatment intervention for that problem sooner, which makes your prognosis better. When we look at prognosis, one of the things that we look at is how soon did you start the treatment intervention after the problem started. And that's why chronic issues, I always say, are so much harder to deal with than something that's acute, because it's obviously been going on for longer. And so this is the issue. When you have numbness and tingling, pins and needles sensation, a burning sensation, all these different types of neurological signs and symptoms, it's not enough to just dismiss it and say, it's just a pinched nerve. It'll get better. Come in, get it checked out. It's very, very simple. I can do a complete neurological exam on almost anybody. And that neurological exam can very quickly pick up if there's things that are more concerning that need to be investigated further. And at least you can have peace of mind that if you are experiencing something like that it's not something that's overly serious, like a neurodegenerative disorder.
The seasonal change thing is weird, though.
Yeah, it is.
Why is that a factor?
It's hard to say. I don't know that there's any concrete evidence to suggest why it's a factor. I just think, when I try to think of it theoretically, is our bodies like to adapt to anything. It's the very reason why when you're trying to lose weight, if you keep doing the same thing, you adapt. Our bodies like adapting to environments. It conserves energy when you do that, right? And if you base it on Darwin's theory of everything should be about energy conservation, it makes the most sense that's why we would just adapt to certain climates. And as you now start to change into another climate, well, now things start to change. Your body starts to respond to that. And, we're often going from cold to hot. And so that change obviously affects, even from a biochemical perspective, our body, the ways molecules move and react. And so I've met tons of people that are, not necessarily born here in Ontario and Toronto, but are from other places in the world. And when they go back home and visit, it's not uncommon for me to hear, oh, I was back home, and back home might be a nice, beautiful, warm climate. And they say, I was back home in Jamaica or wherever it was, and I had no pain. I felt great. I felt amazing. Yeah. But as soon as I came here, I feel it again. I think it's the weather. Now, it could be the weather, could also be psychological, because going on a vacation is obviously nice, and coming back here to reality where you have mortgage payments and work to do is a little bit more stressful. And so that's very, very important, is understanding the psychological component of that as well. But I do believe that our climate, because of how drastic the changes can be, sometimes day to day, like the other day,
29 then 17.
Yeah, exactly.
Crazy.
So those drastic changes definitely are going to be felt in your body. And so that's a lot of the times what we see. And for whatever reason, I've noted it in practice myself, and I know a lot of my colleagues have noted it, that in these periods of changes, we start to see that pain either increases or increases in certain areas for whatever reason. So I'm not sure that there's a good evidence-based answer for it, but that's kind of my theoretical, hypothetical reason for it. Yeah,
we'll take a short one. Your phone calls, bring them on. Would love to talk to you. Pain concerns, health concerns here. The phone lines are open till 1 o'clock this afternoon. 416-870-6400 star 640 on cell. You want to get a hold of Dr. Lou? It's simple. info@paincarecanada.com. Get that free consultation happening. 1-855-821. Pardon me. 1-855-855 Dr. Lou. Jeez, I'll get it on one of these days. It's been a long day, son. More coming up. Hang on. 1216 Dr. Payne Show. Free consultation. 1-855-55 Dr. Lou. DRLOU. info@paincarecanada.com. And of course, the phone lines here at the radio station are ready to go until 1 o'clock. 416-870-6400 star 640 on your cell. Robert, good afternoon.
Good afternoon. How are you?
Good, sir. What's going on with you?
Well, I'll give you a little bit of history. I had my lower back fused up in 2000. I had my neck fused up in 2003. They went through the front. And to top it off, March 31st, 2015, I was moving something up my my basement stairs. I fell down, and I broke my neck.
Ah, jeez, man.
So I had surgery for that as well.
Wow. 3 surgeries.
3 surgeries.
Okay, and now what?
Well, I'm still getting a lot of residual pain from my neck.
Right. Yeah. Where?
I'm sorry.
So they did they fused your cervical spine, you said?
Yes, they did. Yeah.
What level?
Then I broke my neck, and then they had to operate again.
Sure. What level did they fuse originally?
C3 and 4, I believe.
Okay, and then what area did you break?
I fractured vertebrae above that.
Okay.
And I also dislocated T1.
T1, okay, so above and below. Yeah, so here's the issue with surgery for pain. Whenever you look at spine surgery is important, and what I'll say is 2 main things. Impairment of function, so if you can't move for whatever reason, and there's, an impingement on the nerve that's really bad, and you got to get the pressure off just so you can get some mobility back, surgery is very good. And then otherwise, if there's neurological impairment, when the nerve is being compressed so much by something that it's starting to damage the extent of that nerve, so it's causing loss of muscle mass or strength, bad sensory problems, loss of reflex, things like that, that's usually a good indication for surgery. The unfortunate reality about surgery is it does good things on if there's an impairment in function or impairment in neurological function. It sometimes doesn't do very much for pain, and in fact, long term, there can be pain being created in other areas. So whereas you may have had pain originally at C3, 4, and then they go in and fuse it, even if we eliminate the fact that you fractured other areas, and let's just stick with trying to keep it simple, that those areas, once you fuse that C3, 4 area, well, now C2, 3 and C4, 5 have to move a little bit more. Yeah,
they're doing the work for the others.
Yeah.
Exactly, and that compensation. Now, see, the joints of the body kind of want to work on a spectrum where you can have people not enough movement in a joint and way too much movement in a joint. And so we often call that something like hypermobile or very, very tonic. And somewhere in the middle is where you would want. Now, the spine, because of how complex it is and how many different joints are at every level, and then looking at it as a whole unit, once you eliminate the movement in one area, other areas pick up that slack and start moving a lot more. So now you have an area that's moving a lot less, which we just said is not good. And then you have a bunch of areas moving a lot too much, which we also said is not good. And so you remove that harmony of that balance. And so that's been the long-term issue with when they used to go in and kind of fuse discs and things like that, is that there's still going to be a pain component likely because of how many things change from a compensation standpoint. But does that mean that you can never have your pain to a manageable level? No, that's not the case. The key to when these things are done is how do you then find the harmony?
Right.
And usually the answer to that key is the rehabilitation component, the proper.
Well, I'll tell you, as far as rehab goes, I tried the clinical rehab, and all they did was give me a bunch of, which I call sissy exercises to do.
Yep.
And tell you the truth, when I went on my own and started, because I used to be a competitive hockey player, and because I hit the weights, I started building. I hit that pain threshold, and then I'd push myself through. Mm-hmm. And go as far as I could. Yeah. And what I noticed was that pain threshold would move up the scale on its own if I did that.
Right.
So I've managed it, as best as I possibly can. Because if you looked at me, you'd say right away, "Well, this guy works out," just by looking at me. But having said that, I still get a lot of debilitating residual pain, which is from the surgery, I believe.
Right.
They can't fix everything.
No, they can't. And another issue becomes, the important thing with clinical rehabilitation is, yes, in the beginning it may seem, especially to someone who's used to doing much more intense things, it may seem like it's not doing enough. But the key with rehabilitation is it rehabs areas that you often don't use and often there is a clinical weakness in. Mm-hmm. And so it's, the harder thing to say is when people come into my office and I say, okay, I'm recommending, for example, that you get chiropractic treatment. They'll turn around and they'll say, no, I've already had chiropractic treatment. And I turn around and I say, not with my team. And that's the big difference. It's the outlook of the clinician and how they're doing these things, because to just broadly say clinical rehabilitation or physiotherapy doesn't know justice. We have to understand exactly what premise and what theory those things are being done on, and that will improve the prognosis if it's done properly. And that's exactly why I do what I'm doing, is because I've built a team with a vision on how to go about this stuff with the best evidence care possible.
416-870-6400 star 640 on cell. Steve, I see you there. Hang on. Your phone calls as well. We have open lines. We'd love to talk to you. You have pain concerns, rehab concerns, health concerns. Bring them on. The Dr. Payne Show, Talk Radio, AM 640. Love talking to you. Your phone calls, getting to them as many as we can throughout the afternoon. Here's Steve. Thanks for hanging in, fella. How are you?
Not too bad. Thanks for taking my call.
Sure. What's your concern?
About a year ago last September, it's been about 20 months now, I had a car accident where somebody rear-ended me. I went and had an MRI done, I had all the x-rays done, and they couldn't find anything, but I have chronic pain in my neck, and I get super migraines. The pain in my neck, when I put my head on my pillow, it's like there's a bone that's cracked and it's opening up. So I wake up a couple times a night. Anyway, they couldn't find anything, so they sent me to a pain specialist, and he's got me on medication that I take regularly, and now because it's still there, he's recommending that I get, first it was Botox injections to help with the migraines. Now he's recommending that I do injections that'll freeze the back of my head and my neck. Mm-hmm. And I'm kind of concerned about stuff like that because when I asked him what kind of side effects can happen, what's the downside, he said that I could have a catastrophic or emergency where I have to be rushed to the hospital.
That's a bit of a side effect.
That's a little bit of a side effect. It concerns me because I've got a 6-year-old at home, and I don't want to make things worse than they are now. They're already bad enough.
Yeah. So, Steve, what other treatment interventions have you done? Any type of rehab?
Yeah, I went to rehab right after the accident. Went there for about 4 months. There was a lot of different things going on, and they fixed pretty much every one of them, but they couldn't fix the neck and the migraines.
So what did they do for the neck?
basically they did where they tilt my head upwards and then massage my neck trying to get any because they thought it might just be a kink in a muscle or something. Mm-hmm. But other than that, when I went back to the doctor after that, they sent me to a pain specialist who's a really good guy, mm-hmm. and the medication does help. If I take this pill if I feel a migraine coming on, he says take one of these pills and it works, mm-hmm. For the most part. But for the neck, it's almost like I don't know I can't remember what medication it is, but he says take it at 7 o'clock every night, and if I take it at 7 o'clock every night, I do have a little bit of relief, but I still wake up a couple times in the night and my neck's killing me.
Yeah, right. Well, one of the biggest things with car accidents, especially when they affect the neck and cause the whiplash disorder, is, again, the proper rehabilitation of the right muscles. Now, the problem that often happens clinically is when we think about the neck, we think about the muscles at the back of the neck that we can actually mm-hmm. touch. What we often don't realize with whiplash is it actually affects something called the deep neck flexor group of muscles, which are actually, if we were to rip away the throat and look at the front of the cervical spine, that's where those muscles are. And those muscles are very, very rarely treated properly clinically for, one, because it's obviously almost impossible to get there because you'd have to move so many structures out of the way. And secondly, patients usually just want their necks kind of to be massaged. So that's something that I always think is important is if you've done proper rehabilitation for a whiplash disorder, not just, working on muscles to try to remove tension. That doesn't rehabilitate a muscle. That just can be important in terms of temporary relief or removing, whatever type of knot is in that muscle at that time.
It's more of a Band-Aid, though, isn't it? Really?
Yeah, and it also helps, one of the keys with passive treatment and active treatment is you do that type of therapy followed by the rehabilitation so that your neck is healthy while you're trying to do the rehabilitation.
Right.
And then the rehab is supposed to hold the effect of the passive therapy. So in my experience, a lot of the times that's what's done wrong is that the neck is actually not rehabilitated properly, which is why a lot of people get like what you have, Steve, which is chronic neck pain and then some type of a headache that goes along with it. The next thing on the headache front with the migraines is starting to understand the triggers, like when it happens, which is when I always talk about headache diary. So creating something where you can specifically track everything going on with relation to that. In terms of injections, because I guess your question is, are injections something that you should be considering? Again, the answer is it depends. It's very hard for me. There are times that I do recommend to patients, yes, injection is the option for you at this point. And then there are some times when I say, no, it's not the option for you yet. And obviously that is much easier to answer in terms of an assessment that I do with someone versus just generally saying as a broad stroke answer that yes, they're okay or no, they're not okay. I believe everything has a place in healthcare. And yeah, could injections be something beneficial for you? Potentially. Could they be harmful? Potentially. It really depends on your clinical case that I'd have to understand further. And so if you're interested in that, we can have a consultation off air for that.
Yeah, absolutely. I definitely, and I would get your number. But where the pain in my neck is, when your neck goes down and then it turns out into your back?
Yep.
It's right on the top of that spot where it turns.
Right, yeah.
And it literally feels like a bone. That's the only way I can explain it. It feels like a bone has a crack and the crack's opening up when you put your head down.
Right. Yeah, I mean...
I would love to get your number
sure.
So I can contact you afterwards.
Yeah, beautiful. Yeah. No problem.
You want to do it, John?
Yeah, I'll give it to you. Give it to you right now. See if it's 1-855-55 Dr. Lou, DRLOU. 1-855-55 Dr. Lou. Very simple. For everyone else calling in, you got lots of time. 12:30 to talk to Dr. Lou here. You have questions, queries, pain. Bring it on. 416-870-6400 *640 on sale. Dr. Payne Show. Talk Radio. AM 640. And offering free consultation as well, 1-855-55 Dr. Lou, DRLOU, and info@paincarecanada.com. Julie, thanks for hanging on there. How are you?
Oh, very well. Thank you very much for having the show. It's a boon.
Oh, great. Glad you like it. What's your concern?
I had damage in my back about a year ago. I'm a very active lady. I taught fitness for many years, and I want to get back to being fit. The problem is I fell about a year ago, and it didn't start showing until recently. It hurts when I wake up in the morning. Once I get moving, I kind of move it out of me, and I have parts of my day that I don't even know I have back pain. But sometimes I get up and it takes me a long time to get to that spot where it doesn't hurt. Hot baths help. Voltaren helps. I use that as a product. Sometimes that helps. And it goes down into my hips. So I, being very fit, stopped doing all the things I do. Yoga, exercise, and many other things in the last year. And I feel my fitness level going down, down, down. And I'm afraid to exercise because I can push it to the point where I can actually twist my back into a very gentle yoga twist, not pushing anything. And I'll hear noises in my back, like popping or whatever, and it feels better for a little while.
Right.
This may not be good. I don't know whether it's good or not. I don't know whether I'm squeezing discs, or is it okay to continue exercising gently where there's no pain?
Okay, so let me ask you a couple things, Julie. Number one, how old are you?
I'm 66.
66, okay.
I'm very slim. I look a little bit like a well-known person.
Okay.
People say, oh, my God, you look like Sally Fields.
Okay.
But my fitness level is going down, and I don't want it to.
Okay.
And I want to go back gently, but when I take charge of this, the x-rays gave the doctors nothing.
Okay, and that was my next question. So who have you seen? You've seen your family doctor about this?
I saw a family doctor. Yep. I saw another family doctor, and they both did x-rays. I was going from one person a few years ago, a year ago, when it actually sort of happened the most. And then I went back because there was a small lump on that spot.
Okay.
Under the skin.
So besides your family doctors and the 2 sets of x-rays, anything else done?
No, nothing else.
No,
nothing else.
Okay,
Just
so
me.
Oftentimes x-rays reveal very, very little relevant information about the low back. And so it's not often a good imaging. It's not that it's not good. It has to correlate with the person's symptoms. And so you may sometimes see incidental things on x-rays, and a lot of the times people, family physicians will just kind of default and say, oh yeah, you have degenerative disc disease and that's the reason for your pain. And the research on that is pretty clear. It's about 50-50, which means that not all the time does degenerative disc disease. In fact, 50% of the time degenerative disc disease does not account for somebody's pain. So you have to look at it clinically. So I would say you have to, first off, I always say the treatment intervention is based on the diagnosis. So we got to take a look at it. We got to figure out exactly what is causing the back pain. And once we can figure that out, then that's when you can make proper recommendations on, okay, here's what you should be doing. Here's what you should be avoiding. Here are some of the treatment options that you have, et cetera, et cetera. So back pain sits on a spectrum, but pain it could be due to many, many different things. On one end, it could be the benign things, simple muscle strains, to disc issues. And on another side, it can be red flag types of things, cancers, infections, which it doesn't sound like that's the side you're on. Now, obviously, I can't be sure about anything over the radio, but none of the symptoms that you're describing shoot red flags out to me. They do suggest to me that you're on the benign side of the spectrum, but still being on that benign side, there's a lot of different things that could be going on wrong. And the recommendations, say, for something like a stenosis would be very different than the recommendations for, say, something like a disc herniation or for a muscle strain. And so that's very important, is trying to figure out exactly what the pain generating structure is. And once we can understand that, then we can understand exactly how you treat it and get it better. Does that make sense?
Yes, it does. And also, I do trust that there is something that's not the way it used to be.
Yeah, of course. Well, the reality about back pain, especially the fact that it's been going on, is, once you experience it, it's very unlikely that you'll ever get rid of it for sure ever again. But can you get pain down to a level that's manageable and doesn't affect your day-to-day life? Absolutely. It shouldn't be getting progressively worse. It should be something, that is managed. And so it doesn't sound like this is something that's, it is starting to affect your daily life, the quality of your life. And so you'd want to start reintegrating into the right things. And a lot of the times, once you have an understanding, because right now, one of the big things that you said is you're afraid to do certain things. That, fear comes from also not understanding exactly what's going on.
Yeah.
So once you can have an understanding, and this is something that I really, really, really pride myself in doing with my patients, is making them understand exactly what's going on, what they should be doing and what they shouldn't be doing. So you eliminate that fear avoidance behavior, because that fear also contributes to pain. And the psychological component of pain. So we have to overcome that hurdle as well. So if you're interested, please give me a call, or I have your number here if you leave it with our call screener, and I will definitely give you a call and follow up on this.
Julie, 1-855-55 Lou, 1-855-55-DRLOU is the number. Info at paincarecanada.com. Get your free consultation happening for you as well. You'll want to give us a call on the air. We'd love to talk to you. John, I see you there. Hang on, fella. We'll get to you. 416-870-6400, star 640 on cell. Dr. Payne Show, Talk Radio, AM 640. It is 12:53. Dr. Payne Show, Dr. Lou is here till 1 o'clock answering your calls. Got to get to John on the line. John, g'day.
How are you?
Good. What's going on with you?
Just a brief history. Male, 66, not overweight, good shape. 4 years ago, I flew to France, came back, and my arm started to throb.
Right.
Went to the doctor. They did the x-rays, they did the CAT scans, they did the MRI, referred me to a neurosurgeon, Dr. Michael Chapman, at Scarborough General. He basically, this is of course the long waiting period, et cetera, et cetera, et cetera. What I was told was I have bone spurs growing on my spine and in my neck, which are pushing into the nerve centers, which is causing basically problems in my arm. I've lost feeling in my lower two fingers. It's dead as a doorknob. He said there's not much they can do about it. And then 2 years ago, my leg started to throb the same way. So again, we go through the process of, the x-rays, the MRIs, et cetera, et cetera, et cetera, and told that I've got lower bone spurs as well. And so in the interim, Dr. Chapman had retired, so I was in the wind. And my doctor had to go to send out my case to 4 different neurosurgeons before one would respond. And basically, while I was in Florida last year, I saw an advertisement for the Laser Spine Clinic. And they said, oh, yeah, we can have you in 2 weeks. You'll be treated as an outpatient. We can take care of that. Just send us your MRI information, et cetera, et cetera. But they did find a doctor for me up here in Canada because it's $22,000 US per incision down in the States.
Nice.
Right.
So they found a doctor for me, and they had an appointment for me for December the 24th of 2016, December 14th of 2016. So I show up. The door's locked. I knock on the door. Nobody's there.
That's not a good sign.
Standing there. So 10 minutes later, I thought they were out for lunch. So 10 minutes later, I hear some rustling behind the door. So I knock on the door. And the lady comes and says, can I help you? I says, yeah, I'm here to see the doctor. She says, he's not here. I said, excuse me? I just drove in from Oshawa to see him.
Right.
She says, come on. She says, come in. She says, oh, your appointment's for December the 14th of 2017.
No, a year early.
Yeah, exactly, right?
Your parking would be a little high.
Story short, I've started doing hamstring stretches to help tilt the pelvis back, so that's relieved the pain in my leg.
Right.
But the problem in my arm is getting worse. It's seizing up.
Yep.
I'll turn my hand a certain way,
Right.
and I have to manually move it back in order to get it to work again.
Yep.
That sort of thing. Is there anything that can be done for the neck? I mean, I'm doing what I can for the leg, but is there anything that can be done for the neck?
Yeah, so when you start to get bone spurring, and that's essentially when we talk about degenerative disc disease, this is where it becomes relevant, is that bone spurs happen because as bones get closer and touch each other, they lay down calcium, and as that calcium calcifies, it becomes bone, and so that's where spurring comes from. And if the spurring was somewhere where it wasn't near the nerve, it wouldn't cause any issues.
You wouldn't even know, right?
No, you wouldn't even know. It's once it starts to abut against the nerve root or the spinal cord that you start to get the symptoms that John is describing. And John is right. There's, with the absence of some type of neurosurgery, there's not much that can be done. However, clinically, the same way that you can find positions of relief in the low back, because once you understand the mechanics and the movement of the spine, and you look at where those spurs are affecting the nerve, you can understand that certain motions are going to be favorable towards eliminating the symptoms, and other motions are going to be unfavorable and aggravate the symptoms. And clinically, John, I'd have to answer that question by actually reviewing the stuff that you have. It would be almost impossible for me to say it over the radio, because I'd have to see exactly where the spurring is, what your symptoms are like clinically, and then I could make a recommendation on some things that you could do day to day that could help, at the very least, ease your symptoms. In terms of the laser spine surgery, it's not very common here in Canada, so I'm not well versed in it. I know in the States that they're advertising that you can get in and out, like you said, in a week or 2 weeks, and but there's a big price tag to it, and so. In the absence of surgery to remove the spurring and remove the pressure, there are some type of mechanical things that can be done. But again, I would have to assess it from the imaging that you have available to be very specific on that. So, we have your number, or call 1-855-55-DRLOU. Leave me a message with your name and number. I'll get back to you now. And that goes for anybody listening.
Yep, free consultation.
Free consultations.
Yep.
Just call me, leave me a number. You don't have to come in. We can have a conversation over the phone about anything you've got going on. You can call at any time. I'll get back to you within 48 hours.
Again, 1-855-55-Dr. Lou. We'll get to Paul here quickly before break. Hey, Paulie.
Oh, hi.
How are you doing?
Very good. I'll make it quick. 4 years ago, I was T-boned on the job. The passenger, my first symptom was a numbness in the right arm with concussion syndrome. 2 years of severe agony of headaches and just with concussion. It's been 4 years now. I never suffered any neck pain. They're saying it's facet joint damage C1, C2, but now what aggravates the headaches is like stress, lack of sleep. I don't know if I'm still going through a concussion now. This has been settled in court. It's all been settled, all said and done. And my work has me on light duties that they don't really bother me at all in a sense. So, however, it is that I'm 57. So that was the key symptom, was severe headaches for 2 years, trouble sleeping. I'm on a sleep apnea machine after the injury. And again, I lost a lot of muscle mass due to the lack of the weightlifting.
Yeah.
So the chief complaint here is headaches,
right?
Lack of sleep, severe stress, and with facet joint damage, C1, C2, I don't know what else I can do. The specialist therapist really worked my neck a lot, and I have restricted motion, again in the neck. I've been hearing a lot of neck situations on your show.
Yeah.
What else can be done? I'm 57, 3 years before I retire, and I work in the emergency medical field.
Right. Yeah, so again, I would have to, again, take a look at it to give very specific answers in terms of what can specifically be done for your case. One thing that I can tell you from a concussion standpoint after these accidents is that the vestibular rehabilitation for concussion-based symptoms is often done very poorly because it's not taking into consideration proper, and this may not be the case with what you had done, but as a general rule of kind of what I see is that, people often focus on the neck component and they forget to focus on the hearing and the eye component of the vestibular system, and that becomes equally important. So I would say the best answer in terms of what can specifically be done for you, and this goes kind of for everybody when you're thinking about specifically, is come see me. Let's take a look at it. I will get you in very quickly. Everything will be on time. Full hour. We'll go through everything, and then I can make those specific recommendations. And if I think there's something else that can be done, obviously I'm going to tell you, and I'm going to point you in the right direction.
1-855-55 Dr. Lou, DRLU is the number to call. Get that consultation happening. Free consultation, info@paincarecanada.com. And if you're thinking of calling in here to the station to ask Dr. Lou a question over the next few minutes, this is the time you want to do it. 416-870-6400, star 640 on cell. Dr. Payne Show, Talk Radio, AM 640. All righty, 12:54. Hello, time shift. We got a couple in here. Grace.
Hi.
Hi.
Hi. Thank you so much for taking my call.
What's going on with you?
Okay, so long story short, I was having debilitating back pain, and a doctor said just go across the street to the walk-in clinic. Went to the walk-in clinic. They did some blood work.
Okay.
and told me that I had lupus. I said, okay.
Just this was the walk-in clinic told you that?
The walk-in clinic recommended I go to a doctor, a rheumatologist.
Okay, yeah.
The rheumatologist said I had lupus.
Okay.
I said, okay. A year and a half later, they're still testing. The test is positive, but I don't know why it's not. It's weird. Mm-hmm. But anyhow, I've heard that I have a degenerative disc in my lower back.
Right.
I also heard that I rheumatoid arthritis, and I haven't had a complete positive on the lupus as yet. Now, the pain in my back, it gets to the point where I literally cannot move. Mm-hmm. My question and my confusion is that with this degenerative disc, I'm not sure I understand it. Does that mean that what's causing the pain is just going to get worse until I can't walk? I'm just very confused about what is actually wrong with me. Sure. And how is lupus affiliated with it. Yep. Today was a particularly difficult day. It took me about 3 or 4 hours before I was physically mobile.
So sorry to interrupt, Grace. You also mentioned something about rheumatoid arthritis. They've diagnosed you with that as well?
My family doctor said I have rheumatoid arthritis.
Okay, well, it should be a rheumatologist telling you that. So let's start with degenerative disc disease. What degenerative disc disease is, if we were to look at a model spine, there's vertebrae, and in between two vertebrae, there's a disc. There should be, discs are, the best analogy that I give everybody is they're kind of like a jelly-filled donut, okay? And they just really are meant to absorb shock. As we go through life, naturally, as we get older, even at 20, 30 years old, you don't have to be very old, those discs start to lose the amount of hydration that they have. What happens then is the vertebrae start to get a little bit closer. That's what we call degenerative disc disease. It's the same thing that we would use in any joint. So if we looked at the knee and we looked at the joint space, and the joint space was a little bit less than what we would assume is normal in a healthy person, we would say that's degenerative joint disease. Mm-hmm. In the spine, we say disc because it's a disc instead of a joint, whatever. But that's all that term means, is that that disc is a little bit, the two bones are a little bit more approximated than what we would hope for in an ideal scenario. Now, as I was talking to the other caller about, is degenerative disc disease is often not overly important clinically. Having said that, when you look at wear and tear on the spine and at any joint, I always tell people you can look at two types of arthritis. You can look at osteoarthritis, which is the wear and tear, the normal stuff that we all go through. But then there's a whole other class of arthritides called the autoimmune sector, which is kind of the realm that it sounds like you're dealing in if people are telling you things like lupus and rheumatoid arthritis, which are autoimmune disorders. Autoimmune disorders means that your immune system is attacking your body, and in turn your body is attacking things like your joints. And so now what would become important for me is to understand, is the degeneration that you're facing related to the autoimmune insult that you're having on your body, or is it just the normal wear and tear? And it sounds like, a lot of the things that you're being told, those types of things, lupus and rheumatoid arthritis, should be getting diagnosed by a rheumatologist. It's not really something that a family doctor should necessarily be saying. They should be sending it to a rheumatologist to make that final call. But is this something that you may not, like you said, be able to walk from one day? It's very hard to say. Again, I would have to understand, is the degeneration that you're facing just due to normal wear and tear, or is it as a result of the autoimmune issues that are going on in your body? And so other testing would start to point us in the right direction. So things like a bone scan would look for inflammation in specific joints, and that would indicate that maybe it's not just normal wear and tear, but actually an inflammatory process going on. So, give me a call, Grace. Let's go through this. This is a perfect example of a consultation and then moving towards the assessment, where we can definitely take a look at this, see what's going on, and help make the right recommendations for care. And that's open to anybody that's listening.
Another good week, pal. 1-855-55 Dr. Lou, DRLOU, info@paincarecanada.com. We will be going 2 hours starting at 11 next weekend, right?
That's right.
Dr. Payne Show back next weekend. Talk Radio AM 640.